Thursday in discussing non-Hodgkin lymphoma. So remember we had talked about Hodgkin, and I said we were going to talk a little bit about the differences between the two when we concluded our time together this morning. So let's do that first, and then we'll get into some of the other alterations with platelets, and then at the end of the day we'll get a little bit into some of the alterations with the kiddos. So let me make sure I pull up my right notes here. All right, here we go. So non-Hodgkin lymphoma is sort of just a generic term for an umbrella for a diverse group of other lymphomas that aren't sort of categorized under the Hodgkin lymphoma. So the new classification of how they look at lymphomas are really based on cell type, so whether it's the T cells, the B cells, the natural killer cells. They also look at it differentiated on a lot of different sort of unique features. So sort of the etiology, how those cells and how those how the malignant cells sort of respond to therapies. Again, one of the big differentiations diagnostically or sort of clinically speaking is that there is a lack of those Reed-Sternberg cells in non-Hodgkin lymphoma. And there are some other cellular changes that aren't necessarily characteristic of Hodgkin lymphoma either. And so non-Hodgkin lymphoma you can sort of think of as sort of this umbrella of the other types of lymphomas, really, that don't fit into that Hodgkin lymphoma category. So they just kind of made another category for that. When looking at, if you go on to the next slide, when looking at non-Hodgkin lymphomas, oftentimes there's a lot of different reasons for sort of why those malignancies sort of occur in the first place on those cells. So some of them are linked to actually sort of chromosome translocation, so sort of like a chromosomal sort of predisposition. Others are linked more to some type of bacterial or viral infection or other things in the environment. The thing with non-Hodgkin lymphomas, though, that these malignant changes that occur can occur any time along the stages of sort of maturation or development of these cells. So that's, that being said, these cancers can really present with a variety of clinical states and a variety of clinical sort of severities, so to speak, because of the way that this type of lymphoma, this type of malignancy can occur across sort of the lifespan or the maturation span, so to speak, of these cells. And sort of for that same reason, the fact that these, because these malignant changes can occur at any stage along this way, oftentimes non-Hodgkin lymphoma, if you want to sort of think of one as more aggressive than the other, non-Hodgkin lymphoma is oftentimes more of an aggressive form of lymphoma than Hodgkin's that we talked about on Monday, or Thursday, whatever today is. Yeah. Another thing when thinking about non-Hodgkin lymphoma is that, remember, put your thinking caps on way back to last semester. We talked about cancer and sort of the processes in which cancer begins. And we talked about those two types of genes, the proto-oncogenes and the tumor suppressor genes. Remember, tumor suppressor genes under normal healthy circumstances are the things that sort of run surveillance in our body and keep those tumors at bay, keep abnormal cellular growth from occurring. And proto-oncogenes we want to try to always keep turned off so that, they're the cells that do want to overproliferate and do want to cause problems. So under normal circumstances, we want proto-oncogenes to be off and tumor suppressor genes to be on, right? We talked about that, Kathy's lecture last semester. The issue in non-Hodgkin lymphoma is that you've got some alterations in both of those genes now. So the proto-oncogenes now, unfortunately, do get flipped on, and the tumor suppressor genes get flipped off, unfortunately. And it's these changes that contribute to, unfortunately, some cell immortality, which is, never usually good, right? We don't want cells to live forever. So contribute to cell immortality and then an increase in this formation of malignant lymphocytes. So again, it's this combination, this bad combination of turning on proto-oncogenes and turning off tumor suppressor genes that lead to some of these malignant cells. Again, another sort of thing to keep in mind to kind of help differentiate non-Hodgkin's from Hodgkin in your mind is that usually non-Hodgkin's lymphoma is a disease more of middle age. So you're usually found in people of 50 years or even older, as opposed to Hodgkin lymphoma tend to be younger. So these are the people that you're hearing of get lymphoma that are like in their 20s or 30s. So, but non-Hodgkin's is certainly an older population. Okay, so in terms of clinical manifestations, again, there are some differences between the two forms of lymphomas. So with non-Hodgkin's, you usually begin as they can be sort of localized or generalized lymphadenopathy. And again, remember that means sort of the inflammation, the swelling, and just enlargement, so to speak, of those lymph nodes. The difference, though, between non-Hodgkin's versus Hodgkin's that we talked about on Monday is that non-Hodgkin's tend to spread, the lymph node spread, tends to spread in a very erratic way. So you could have some lymphadenopathy in one section of the body, and then it's somewhere, way far away in another section of the body. With Hodgkin's that we talked about on Monday, it tends to spread in a very sort of predictable, linear way. So basically just from area of initial sort of lymphadenopathy and then any sort of nodes close to that. So it sort of creates sort of this chain, so to speak, this very linear, going from, the closest lymph nodes out, as opposed to non-Hodgkin's where it's just kind of erratic anywhere. So again, very big difference there in terms of disease progression and disease spread. But again, cervical, axillary, inguinal, and femoral chains are usually the most commonly affected sites. Again, remember we also talked about on Thursday how the swelling of these lymph nodes are usually painless. That's all, like I said, usually not a good sign when you have sort of painless lymphadenopathy, and they feel very hard and fixed as opposed to those sort of soft, mushy grapes you can kind of roll around under the skin. And you'll also see that with these types of nodes that have become enlarged, they really transform over a long period of time, so periods of months or years, really. Treatment for non-Hodgkin's is very similar to Hodgkin's in that it's, chemo and radiation. However, the success really does depend on a lot of factors. So the success of the treatments really do depend on a lot of factors. One, stage of the disease, where in the stage did they catch it. The cell type involved, again, we talked about on Thursday that the less differentiated the cells are, the more aggressive that particular disease is, right? We talked about that on Monday. So cell differentiation plays a big part into sort of, what cell type is involved, how well is it going to sort of respond to treatment. Involvement of other organs certainly plays a big part into how, this particular lymphoma responds to treatment, the person's age, and the person's body's sort of their bodily response, their bodily reaction, not only to the disease itself, but to the treatment then as well. So it can be a very individualistic type approach. And again, because I said that this usually tends to be a little bit more aggressive, it tends to be in an older population, the overall survival rates are worse usually than with Hodgkin's. So just sort of keeping those sort of factors in mind. Now, one of the objectives at looking at the difference between these two types of lymphomas is to really sort of compare and contrast the differences of them. So here, I thought I'd just sort of make an easy slide for you to be able to sort of quickly do that. I sort of, summed it up for you in a nice little nutshell. The other thing before we start looking at this graph or this chart, so to speak, I want to just sort of bring out one sort of formatting issue. So when it sort of came up onto the screen, this area right here needs to be shifted over. So this needs to be here under Hodgkin, and this needs to be here under non-Hodgkin's. These are both sort of still under this nodal involvement category. I'm not sure why when it got formatted it sort of tabbed over. So again, this talking about mesenteric nodes needs to be here under Hodgkin lymphoma, and this needs to be here. Again, these are all part of this nodal involvement category. So the characteristics that I have pulled out here for you to sort of be able to look at the differences of are nodal involvement between the two, spread between the two, some of the clinical manifestations of sort of what you see in one versus the other, extranodal involvement, and then the extent of the disease. The ones that I specifically want to sort of bring to your close attention is, in terms of differences, is spread. Again, remember I just said that non-Hodgkin's, oftentimes the spread of, from node to node is very non-contiguous. It's not necessarily in a linear sort of planned fashion. as opposed to Hodgkin's is very orderly, spread by contiguity. So you kind of know if it starts in one area, you kind of can sort of plan or sort of expect or anticipate where that disease will progress. Not so with non-Hodgkin's. Again, also leading to one of those factors of why it's a little bit more aggressive and harder to treat. The other thing I really want to sort of point out to you is the manifestations. So very common to see fever, weight loss, and night sweats with Hodgkin's, not so with non-Hodgkin's. Again, another one I want to sort of point out to you is extranodal involvement, so meaning other organs that can be involved, those types of things. Very rare in Hodgkin's and very common in non-Hodgkin's. Again, all sort of pointing that finger to sort of the reason why non-Hodgkin's is a little bit more aggressive and harder to treat. Okay. And again, just wanted to kind of lay it out for you clearly here. It is an objective, and I wanted to point out sort of the main things that I want you to be aware of in terms of the compare and contrast differences between the two. Okay, any questions about that before we move on to multiple myeloma? Any questions about the two different types of lymphomas from today and Thursday? Okay, all right. Multiple myeloma. So it's definitely it's a malignancy as well, and it's definitely an alteration of the hematologic system. But because B cells mature in the bone marrow, and we know where bone marrow is located, it's also really an alteration of the sort of skeletal system as well, right? So yes, it is a hematologic problem, but it also is bone issue as well. And the reason for that is that these B-cell cancer is characterized by proliferation of malignant plasma cells that sort of infiltrate and sort of take over that bone marrow cavity and aggregate into actual tumor cells. So really these B cells almost kind of turn into and become abnormal B cells that then really make a tumor. And it happens throughout the skeletal system. So it happens anywhere in bone, essentially, that has bone marrow that makes and sort of helps with the maturation of B cells. You can see these neoplasms, these malignancies grow. And it really happens because of it produces cytokines that stimulate, well, actually, no, let me say that in a different way. I don't want to confuse you. In addition to this cancerous process occurring with the B cells, you will also see issues with the bone for this reason, and that is that these abnormal tumors produce cytokines that stimulate osteoclasts to resorb bone. Now, we're going to talk about the musculoskeletal system in our next unit, but if you remember from your previous knowledge, right, osteoclasts are the cells that do what? Mm-hmm. Right, exactly. So they are the cells that are sort of responsible for breaking down bone or what they call reabsorbing or resorbing bone. So not only will you see now these malignancies, but you'll also start to see what if bone is starting to get reabsorbed and starting to get broken down. You're going to see fractures. You're going to see sort of bone thinning, bone breaking down, right? So you'll see bone lesions, and they call them lytic lesions, specifically in multiple myeloma, because it's actually sort of, the breakdown of the bone. So they call them lytic lesions. And you'll also see hypercalcemia. Now, given what was just said regarding osteoclasts, why would you expect? Why would that be sort of a pretty expected manifestation to see increased calcium in the blood? It's being stolen from the bone. It's actually be taken away from the bone, and you're going to see it then be deposited in the blood. So very stereotypical sort of clinical manifestations is bone lesions, or these lytic lesions, is bone breakdown, and hypercalcemia. Good. So in addition, in terms of clinical manifestations, in addition to the hypercalcemia and the painful bone lesions, you'll also see renal failure. Why do you think, given what we just said about hypercalcemia, would it be kind of expected to see some acute renal failure? Why might that be? Anyone know? Yeah.
Because the kidneys are being exhausted from filtering out that
Right. Right, exactly. There's such an over-presence, so to speak, of calcium that, first of all, you may start to see kidney stones. Would not be uncommon at all to see that sort of deposit into excess calcium being deposited into stones. So you'll see issues with kidney stones. And because of that, you can either see sort of blockage of those filtration devices, sort of the glomeruli in the kidney because of these stones lying there to set that person up for sort of an acute kidney failure kind of issue because of issues with filtering, if there's blockages there, and also just because they're getting overused because of the increased calcium in that blood. So it's sort of a double-edged sword there in terms of setting this person up for acute renal failure. Yeah?
Would you see some of the renal failure or kidney stones, could that be like your first indication that something's going on, or does that come later?
Could be. No, it could be. I mean, because anytime you're taking that calcium away from the bone, it's going to happen. So it could be one of the first things you see. One of the probably the most characteristic things you see, though, is the complaint of that really severe, intense bone pain. Yeah. Uh-huh. Yes, why not, right? Because of the issues with the, dysrhythmias with the increased calcium. Absolutely, absolutely. Maybe some issues with bone or with muscle. Would you see over sort of reflexive muscles, or would you see sort of tamping down muscle reflexes with hyper? Good, very good, very good. So any of the manifestations that you would see with high calcium, you would certainly expect in multiple myeloma as well. So hypercalcemia, anything that goes along with that, renal failure, painful bone lesions, very intense. Yes. Oh, there'd be decreased reflexes. Yeah, instead of like twitching and, like overactive muscles, it would be sort of very flaccid, weak muscles because of the increased hypercalcemia. Good. Painful bone lesions, a big one. And then the last one here, anemia. Again, why would you expect to see, if we're talking about B cells and that sort of, conversation, why would you see anemia? Yeah. Yes. 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 She said, would it be the same reason that you would see anemia and leukemia? Exactly. Basically a pancytopenia, right? All cells could possibly be low because of that infiltration and that overcrowding in the bone marrow. Very good. Excellent. All right, and here's a really good picture of that. Some x-rays here of a bone with multiple myeloma. Now we know obviously that the normal x-ray of a bone should look, all of it should look this bright white, sort of glowy white, right? And you see all of these areas of these lytic lesions, right? Of these round, almost like punched out looking places in the bone where the bone has just been reabsorbed. It's just gone. These round punched out regions of bone is obviously going to be extremely painful. So this is the exact reason, or the true side of why you'd have such intense, sort of severe pain with multiple myeloma, but also really, really leading this patient up for risk of pathologic fractures, right? So any sort of minor little bump, any sort of little, minor trauma that would not cause a fracture to us could certainly predispose these people for fractures. And it really doesn't even have to be a bump. It could literally just be a fracture, right, because of the lack of bone mineralization there. So there really wouldn't have to be any reason for this person to just have a spontaneous fracture. So again, true, very classic manifestations of multiple myeloma. Okay, any questions? This sort of concludes our conversation regarding white blood cells. Anything else? There's one here. Yeah. Mm-hmm. Yeah. Well, so these punched out lytic lesions are very classically characteristic to multiple myeloma. Osteoporosis doesn't look quite like this, and it also may not occur as quickly. So the changes to the bone will be more of a slow progression with osteoporosis, as you might start to see this a little bit faster. The other thing is the biopsy. Doing like an aspirate of bone marrow would certainly show you those abnormal cells. Yeah. Good question. Okay, so thus ends our discussion regarding white blood cells. Let's move now to disorders of platelets. Remember, we've talked about red blood cells, white blood cells, and now platelets. Again, for your reference, I have put the normal platelet count there for you. And again, just like the other things the other blood cells we've talked about, both red and white, we can talk about disorders of platelets in the same way, that they can either be quantitative problems, so an issue with the number of platelets being too high or too low, or qualitative problems that can sort of interrupt normal blood coagulation and prevent hemostasis. So let's talk a little bit about both of those. Obviously, the normal platelet count, or shall I say, the platelet count being low would obviously be thrombocytopenia. Platelet count, again, of it being anywhere between 150 to 400. So anything below 150, we're going to go ahead and call it thrombocytopenia. Now, we start to talk about really profound thrombocytopenia when we start to talk about numbers that are sort of like 50 or below. At less than 50, you're going to start to see bleeding from minor traumas that would not normally cause us to bleed, right? So this could be, someone shaving, and under normal circumstances, you put a little dot of toilet paper on it and it stops bleeding. They can't get the bleeding to stop, right? Those types of things. So bleeding from very minor trauma. Under 15,000, you're going to just see spontaneous bleeding. So this is the person who's coming into the emergency room with a nosebleed that just won't stop, and they did not get bumped in the nose, kind of thing. Bleeding gums when brushing their teeth that they just cannot get to stop. That's what we're talking about at platelets less than 15,000-ish. And then really when we're talking even below that, like less than 10,000, this is the kind of severe fatal bleeding that we just can't get to stop, right? This is certainly life-threatening if a platelet count is 10,000 or below. Again, these are also the kinds of people that we're really concerned about. Any sort of bump or any sort of minor anything is going to really cause a hemorrhagic type of experience. So these are the kind of people we're really worried about with getting like spontaneous subdural bleeds. I mean, there's no reason for why they should start bleeding into their head, but they do, right? And it's because their platelet count is so low. So again, we're really concerned at sort of less than 50 and, down. Okay. Yeah, uh-huh. Yeah. Yeah. Do they have a nose? Do they have any bleeding? Really? Huh. It shouldn't, because, and we're going to talk about sickle cell in a little bit when we talk about pediatric considerations. It shouldn't, because that's a true problem with red blood cells. I wonder if he had some other complicating factors going on. Do you know if he did, or? Yeah, it's not. I will tell you, it's not a normal manifestation. It's not a common manifestation of sickle cell. Interesting. Yeah, interesting. He's definitely got something else going on then, maybe. Yeah. Okay, let's talk a little bit about some of the reasons for why you might see some of these profound thrombocytopenias, though. I will tell you the most common form of thrombocytopenia is a result from some type of increased platelet consumption. And what I mean by increased platelet consumption is that the platelets are getting used up for some reason or another. And therefore, if the platelets are getting used up, then you're at a risk for bleeding, right? If there's no platelets there to sort of help with that hemostasis. So let's talk about some of those reasons that can sort of consume these platelets and then set a person up for risk of bleeding. So the first one I have listed here is hypersplenism. And what I basically mean by that is sort of enlargement of the spleen or overaction, so to speak, of the spleen. Given what you know about what we've talked about the spleen, why might that be a pretty good cause of thrombocytopenia? If you've got kind of enlargement and overaction of the spleen. What did we talk about happens in the spleen? It stores, right? You have a lot of platelets actually being sequestered in the spleen. So if you've got overaction or overreaction of the spleen, you'll see too many platelets being sequestered in the spleen and not out in the circulation to help with hemostasis. So that's one really good reason. Another good cause is so some type of autoimmune disease where you see antibodies actually attack the platelets, so antibodies against the platelets. Again, consumption, right? Using up of those platelets, and then therefore there's not enough platelets there to help with hemostasis. You will see it happen sometimes after a viral or a bacterial infection, a pretty profound viral or bacterial infection that causes something called disseminated intravascular coagulation, or DIC. We're going to talk about that pretty specifically in a little bit later on here this morning, but just wanted to mention it here as well. And then you'll also see it in something called heparin-induced thrombocytopenia, or HIT. Anyone familiar with this? Have a patient with it? I see some nodding heads. Anyone want to share a little bit about what they know or pathophysiologically what causes HIT? Anyone want to share? Maybe? No? Yeah? No? Actually, actually, okay, so it's a little confusing, right? Exactly. So think about it. What do you know about heparin? Does it normally, under normal circumstances, is heparin actually supposed to decrease your number of platelets? No. What does it do? What does heparin really do? It's not supposed to wipe out your platelets. What does it do? What does it help prevent? Anyone know? It helps with clot formation, but how? What did you say? I'm sorry, I didn't hear you say.
Block the action of the platelets?
Well, sort of, right? So heparin should normally, under normal circumstances, should help prevent that conversion of fibrinogen to fibrin that we talked about. I guess it was last Monday, that we need that conversion of fibrinogen to fibrin to actually sort of start the clotting cascade, to start the clotting process, right? It also helps inactivate thrombin. So it inactivates any sort of blood thickening or blood clotting. So again, I'll say it again. Heparin under normal circumstances should help with that formation of fibrin, prevent the formation of fibrinogen to fibrin, right? And also helps inactivate thrombin. Okay, so that's why it's a blood thinner. That's why it helps with, making blood thinner and decreasing blood's ability to clot. So under normal circumstances, it really shouldn't actually wipe out the number of platelets. It should just sort of play that part in that clotting cascade. Now, what happens in HIT is that it's sort of a reaction. The body's response or sort of reaction to heparin that's actually characterized by decreased platelet count. So really under normal circumstances, that should not happen. Anyone know why in HIT it does happen? It's almost like an allergic reaction or sort of a immune response to heparin. So you hear sometimes with people who have some sort of an allergy to like bee stings or something, that every time they have another bee sting, their sort of allergic reaction gets worse and worse and more profound. Do you know what I'm saying? Have you heard of this? Okay. So oftentimes HIT will occur in people. Again, it's a very sort of specific reaction, sort of characterized by decreased platelet counts, but it happens because a patient or a person develops antibodies to the heparin. And it's the antibody-antigen reaction that actually wipes out the platelets. And people who are most at risk for these heparin-induced thrombocytopenias are the patients who have maybe become exposed to heparin several times throughout a short period of time. So like a hospitalized patient who's getting heparin for one reason or another is certainly more at risk for developing HIT. Does that make sense? Okay, so you're going to see it in people who have maybe been hospitalized, who have undergone some type of therapeutic reason for heparin, and have been exposed to it many times, sort of longitudinally throughout a period of time. So our saline locks that we use, our IV saline locks that you see all the time on in your patients in clinical. Have you ever heard them referred to sort of anecdotally as HEP locks? Yeah. The reason people sometimes call them HEP locks or heparin locks is because we used to, instead of flushing saline locks with saline to keep them from clotting and to keep them flowing nicely, they used to actually flush them with heparin. Small little doses, small sort of diluted doses of heparin to sort of prevent, a clot forming at the tip of that catheter, internally. Well, what do you think happened after all these people in the hospital got exposed to heparin in these small but frequent little doses? They started developing HIT, right? And so they stopped flushing everybody's IVs with heparin because A, they were developing HIT, and B, we realized you don't need to. You can flush it with saline. You can also prevent clots from forming around the catheter just as well. But that's exactly why why you still hear them referred to as HEP locks, because they used to flush them with heparin. And then people started developing these antibody reactions and got HIT. So again, that is a really good example of a sort of platelet consumptive, the platelets are being used up, they're being consumed, and therefore causing thrombocytopenia. So kind of just a little FYI there for you regarding HIT. Okay. Any questions about true, sort of straightforward thrombocytopenia before we move on to some of the other platelet disorders? Okay. The next one we're going to talk about is immune, or sometimes you'll hear it referred to as idiopathic, thrombocytopenic purpura. Okay, so what this is that it's an immune globulin G antibody that targets platelet glycoprotein. So the glycoproteins on the outside sort of covering of the platelets. And what happens is that these antibodies now, once they sort of attach to the coats, to the outside of the platelets, these antibody-coated platelets get sequestered and removed from the circulation and, taken to the spleen to be destroyed and broken down. So, what do you think happens, right? When all of your platelets have been coated by these immune globulin G antibodies and have been taken out and sequestered, and, they're in the spleen to be destroyed. What do you think happens? A thrombocytopenia, right? Again, the platelets have been consumed. The platelets have been used up and taken out of circulation, and you're going to start to see bleeding. You're going to start to see bleeding risks in these people. Oftentimes, and this does not always have to happen this way, but oftentimes the acute forms of ITP, is what they refer to it as, often develops after some type of viral infection. It's one of the most common reasons for why you see ITP, and it's one of the most common reasons for any type of childhood bleeding disorder is sort of post-viral. It doesn't always have to happen that way, but it's something that you will commonly see in the pediatric population. So, because the rate of platelet destruction is higher than platelet generation, right, you're going to see bleeding. And so that's exactly what you see in terms of manifestations. You're going to see purpura, those big, blotchy, purple bleeding spots under the skin, or petechiae, the small little bleeding in the microcirculation, those little dots of bleeding. And under most circumstances, that's usually what you'll see. But it certainly can progress to sort of more major bleeding risk and more of a hemorrhagic condition. But usually that's what you'll see, petechiae and purpura. Yeah.
For it being after viral
Yeah.
infection,
Uh-huh.
does it have to be like a severe viral infection, or could it be
It's not usually going to be like just your normal sort of upper respiratory kind of viral infection. We'll talk about it a little bit more in the pediatric population as well, but the two main ones that you'll see them quite commonly are like cytomegalovirus and Epstein-Barr, so like after a mono kind of situation. Yeah. Uh-huh. It's almost like it's like an autoimmune kind of thing. Yeah, that's why sometimes you'll hear it referred to as idiopathic, but oftentimes you'll hear it referred to as immune thrombocytopenic. It's like an autoimmune. They're just attacking it for some reason that they don't really know why. Yeah, good question. Yeah.
So this is acute, and as soon as the body stops producing that much IgG or the new platelets get formed, it won't do it again.
Yeah, so usually this is self-limiting. Usually this is, but it can last a while. So you can see this lasting for several months, 1 to 2 to 3 months. And usually after that it's sort of self-limiting and you see a complete remission and it doesn't really happen again. That's usually the normal flow, the normal trajectory of this. It certainly can last longer, and you can certainly have more complications, especially if you've had some major bleeding issues, right? But it's usually pretty self-limiting, and it usually lasts just a few months with complete remission. Now, it's scary as heck, right? Especially as a parent. If you have a child with ITP and you start to see these sort of big purpley bleeding sites under their skin, and it can be all over, it can be all over their skin, it can be in their mucous membrane, so their tongue can look sort of really blacky, bluish purple because they've got bleeding in their tongue and in the inside of their mouth. It can be very scary. And oftentimes, like I said, there is a connection. If you look back in hindsight, there's a connection with some sort of viral load there. But it can be very scary for parents, and they don't always know the link, right? But luckily, usually it is self-limiting and does sort of, reach a full remission. Okay. Any questions about ITP? We'll talk about it a little bit again when we talk about pediatric considerations. All right. The next one we're going to talk about, actually we're going to skip this one. We can actually just skip this. So thrombotic, the rest of this sort of conversation regarding another type of thrombocytopenic purpura, you can just sort of cross off. We're just going to talk about ITP. So you can cross this one off. Anytime you can cross a slide off, I know you like that. Put a big X through that. All right. Now, the next disorder of platelets that we're going to talk about is essential or primary thrombocythemia, right? And so thrombocytopenia is not enough platelets. Now we're talking about too much, right? And thrombocythemia, essential thrombocythemia, is characterized by a platelet count usually way above 600,000. And it is also a myeloproliferative disorder of those platelet precursor cells. Remember what those platelet precursor cells are? Megakaryocytes we talked about, right? That they're sort of those, sort of flake off and become those cell fragments that sort of, as the cell tries to divide, and then platelets are formed. So it really is a myeloproliferative disorder of the megakaryocytes in the bone marrow. And it's just for some reason, right, because of this myeloproliferative disorder, that the bone marrow produces too much megakaryocytes. And so then therefore if there's too many megakaryocytes, there's too many platelets. What do you think you're going to see, clinically speaking, manifest in a situation where there are too many platelets? Thank you. Exactly. Oftentimes you're going to see thrombosis sort of all over. One of the main places you'll see it is in the microvasculature, so in those little capillaries. But you can also see them in large vessels as well, both arterially and in the venous system. One of the things that we're most concerned about, obviously, is not just the true clots in thrombocythemia, but what? If you've got a clot, what else are you worried about? I'm sorry? Hypoxia to the tissue distal to that, right? So the lack of blood flow, the lack of perfusion, the lack of oxygen getting to areas distal to that site, right? So it could be, as sort of peripheral as ischemia in the fingers and toes and hands and feet, if we're talking about a large, thrombus in the circulation in the periphery. But we're also really concerned about major clots in sort of cerebrovascular regions, right, too? So if we've got a big honkin' thrombus sitting in the, arteries to the brain, we're worried about TIA, strokes, etc. So we're really talking about all, complications sort of all through the spectrum, both peripherally and then more cerebrovascular or cardiovascular as well. How do you think you treat it? Just myelosuppressive agents, right? Just treat that overreactive bone marrow. Treat that bone marrow that's churning out these, high numbers of megakaryocytes. So a myelosuppressive agent, which literally just suppresses platelet production. And that's the simple treatment for thrombocythemia. Okay, any questions about that? All right. All right, so now we've finished up our conversation regarding discussions of quantity, either, too many or not enough. Now let's talk about alterations of sort of qualitative problems. So alterations of just the platelet function. So this is to say qualitative alterations in platelet function demonstrate an increased bleeding time in the presence of a normal platelet count. So the platelets look normal. If you were to draw the person's blood clinically and look at their platelet count would be in the normal range. So why are you seeing problems then, right? Because it's some sort of qualitative problem with the function of those platelets itself. It's not that there's not enough of them. It's that there's a problem with the platelets that are there. So platelet function disorders result from platelet membrane glycoprotein deficiencies or a defect in the sort of clotting cascade and sort of the, the steps that occur for a clot to form, or deficiencies in a clotting factor, the presence of clotting factors. So that being said, what do you think, just off the top of your head, may be a true disorder that would really fit really well into this sort of category? What do you think? It's not a problem with the platelets. It's a problem with the clotting cascade or deficiency of clotting factor that causes bleeding. Hemophilia. Very good. The platelet count, the platelet number in hemophilia is perfectly fine. There's a qualitative problem to the clotting process, to the clotting factors. Good. Very good. So be it hemophilia or be it any other type of qualitative platelet function problem, manifestations are going to look similar, right? You're going to see issues with bleeding, right? You're going to see petechiae, purpura, mucosal bleeding, gingival bleeding, spontaneous bruising or bleeding, exactly. And the disorders can be either congenital or they can be acquired. So hemophilia would certainly fall under the category of congenital, right? That, you're sort of born with it, it's a genetic kind of thing, as opposed to acquired. So, let's see. We're going to talk about hemophilia more specifically when we talk about pediatric populations, so I don't want to steal my thunder right now, and I'll wait for that until we get to the kids. But what I do want to say really quickly under this discussion of qualitative problems with platelet function, I have to talk about vitamin K. So let's talk a little bit about that before we move on to some of these other examples. So vitamin K is necessary for synthesis and regulation of a lot of these clotting activities, right? So it's important for the regulation of prothrombin, the prothrombin factors, and proteins C and S, which are anticoagulants, right? So anyone know what the true sort of function of vitamin K is for us in terms of our bleeding, or shall I say not bleeding? What does it do? It's vital to our clotting cascade, and we are not going to get into sort of all the technicalities of all of our clotting cascades today. But what I want you to understand is that it's vital to the proper functioning of that clotting cascade. So, if you have a vitamin K deficiency, what are we worried about? Bleeding. Right, exactly. Wonderful. Very good. Now, to sort of think about it on the sort of other end of the spectrum, has anyone taken care of a patient who's on Coumadin? Yes, okay, I see lots of heads nodding. Do you know one of the major sort of patient education pieces of patients on Coumadin in terms of like their diet is? To avoid vitamin K, right. Would this make sense to you now about why that's important to avoid vitamin K? If vitamin K helps with clotting, if it helps in the clotting cascade, and you don't want a patient to clot, right, for whatever reason, they're going to be told to stay away from vitamin K. So education would be things like stay away from dark leafy vegetables and things like that. Now, it's not necessarily the best sort of education to tell a patient completely to stay away from dark leafy green vegetables. The issue is to tell them not to change their consumption of dark leafy green vegetables. If they're eating a lot of them, or I should say, they should never eat a lot of them, but if they're eating some of them, don't change. And why is that? Yeah.
You're dosing based upon their current level.
Exactly. So they have, whoever has prescribed Coumadin for this patient has titrated their Coumadin levels according to this patient, right? According to maybe their diet, maybe just the way their body responds to the medication, right? So they have already done the titration. So whatever it is that you're eating in terms of vitamin K, fine, but don't change it. Because if you would then decide to eat nothing but kale salads for a month, delicious, then you're going to mess up that titration with the Coumadin, right? So it's not good enough to just say stay away from vitamin K. It's don't change your normal sort of intake of vitamin K, because vitamin K is an antidote to Coumadin. Now, clinically speaking, like I just said, it is an antidote to Coumadin, and I have actually used vitamin K as an antidote to Coumadin many times in the ER when you have someone coming in either with a, Coumadin overdose, not that they really meant to sort of overdose on Coumadin, but, they've taken too much for some reason, they come in, their bleeding time is way out of whack, and they're truly at risk for sort of spontaneous hemorrhage. I have certainly, given vitamin K as an antidote to that, to sort of help thicken up their blood a little bit, right, and to try to get them out of that dangerous bleeding risk zone. So again, vitamin K can be used as an antidote to Coumadin, but you have to sort of, very specifically educate your patients about the use of vitamin K when talking about, the relationship with Coumadin. Question?
I know there's a bleeding time test.
Yes?
So what time is concerning for bleeding?
Well, you're looking at, so usually it's your prothrombin time that they're looking at, right? And usually therapeutically, if someone's on Coumadin, they want to get the prothrombin time to like 2 or 3 times, how should I say it, longer than normal, than like one of us sitting here. So if we're talking about it even more than that, that's what we're concerned about. Yeah. So it's usually, therapeutically, they usually want it to be 2 to 3 times normal. And if it's more than that, we're certainly concerned about that. All right, good question. All right, so I just want to put my little 2 cents in there about vitamin K. Now, last but not least, to finish our conversation here regarding issues with platelets before we move on to kids. And this is this phenomenon that I have sort of briefly mentioned several times already throughout the last 2 class periods, and that is disseminated intravascular coagulation, or DIC. This is your very true, very classic example of a consumptive thrombohemorrhagic disorder. Now, just that name is confusing. Consumptive thrombohemorrhagic? That doesn't make much sense, right? Bleeding and clotting. Interesting. Let's talk a little bit about why this is, and why it's such a classic, why DIC is such a classic example of a consumptive thrombohemorrhagic disorder. Okay, so to start off with, at the beginning, DIC is a very complex, hopefully the name should give that away, right? Is a very complex acquired disorder in which clotting and hemorrhage can simultaneously occur. What? First of all, DIC is characterized by widespread activation of coagulation. So that's just that normal clotting process that we've talked about already, right? Formation of the fibrin clots in those medium to small vessels throughout the body. So what conditions would cause the clotting process to begin, right? We talked about this last Monday. What conditions cause clotting process to begin? Yeah. Arteriosclerosis, and even more generally than that, endothelial damage, right? Endothelial damage of those vessels. Okay, so examples of damage to the endothelial lining. Cancer, and I actually have this on a slide coming up, but things like cancers, profound infections if someone's septic, that can actually be very, traumatizing, and those vessels can become damaged. Pregnancy complications, maybe not even so much pregnancy complications, but sort of labor and delivery complications. Severe trauma, obviously a lot of my trauma patients are going to sort of be set up for a good candidate for DIC down the road. Okay, so anyway, any reason, any clinical reason why profound endothelial damage has happened is going to set this process up. So again, first of all, it's characterized by widespread activation of coagulation, right? Now, when the amount of activated thrombin exceeds the body's antithrombin, and the thrombin does not sort of remain localized, but it starts to then go elsewhere in the body, you're going to see widespread clotting in these patients, right? Because if the endothelial damage is not just in one little spot, if it's widespread, you're going to see widespread clotting, right? So you're going to see widespread thromboses that then sort of starts to cause problems in the vasculature. So So if you're going to see major widespread clotting going on in the body, you're going to then start to see what? Distal to those clots. Ischemia, right? Again, lack of oxygen, lack of perfusion, lack of proper energy, to the tissues. Okay. So you're going to see widespread ischemia, infarction, organ hypoperfusion, all the things that you would really expect with widespread clotting, right? Okay. Now this is where it starts to get really complex and really tricky in DIC. The magnitude of clotting that occurs in these patients with the magnitude of endothelial damage causes consumption of the platelets and consumption of the clotting factors. And what happens when all of your platelets and all of your clotting factors in your body are wiped out? You're going to start to bleed, right? So that is why DIC is a consumptive thrombohemorrhagic disorder. Because first, you clot, and you clot widespread because of whatever horrific sort of endothelial damage is going on, right? Then then you're going to see all those problems with clotting, lack of perfusion, ischemia, hypoxia to the tissues, all of those sorts of things that you would normally see. So you're going to see all of that very complicated process, and then once all of those factors have been used up, then you're going to start to see another very complicated process in that they start to hemorrhage and you can't get them to stop. Okay? So these are very complicated, very sick patients, and that is the true sort of progression, if you will, of DIC. Okay. So if you don't understand anything about this, anything about DIC, what I really want you to truly get is this last sort of starred bullet right here. The magnitude of clotting may cause consumption of platelets and clotting factors, leading to severe hemorrhage, basically. Okay. So, triggers, I already said, malignancies, infections, pregnancy complications, severe traumatic injury kind of things. So if you think about these clinical examples, these patients that I just sort of gave you here, these patients are already sick as dogs, right? These are already your sort of ICU critical care kind of patient. And then you put this really profound, really complicated process on top of that, and the mortality rate of DIC is super, super high. And again, you may not have seen this already if you're working on the floor, more med-surg kind of units, but once you get more into sort of the critical care areas, you will see DIC. It's a major diagnosis of ICUs, of critical care. Okay, so clinical signs and symptoms and sort of what this would truly sort of look like. One really common sort of, let me just kind of give you a normal sort of picture, a normal trajectory, so to speak. Let's say it is a trauma patient, right? They've been stabilized in the ER. They're coming up now to the trauma surgical ICU. Maybe a day or so later, you start to see some cyanosis, right, of the fingers and the toes and maybe some other places in the body. Okay, that's probably the beginning now of this profound clotting process that's beginning, right? So you're seeing some cyanosis because of the lack of blood flow, right, past the clots, to the toes, to the other areas in the periphery. You also could maybe start to notice in this patient that even though they're on the vent, or even though they are properly being oxygenated in whatever way, let's say they're on a ventilator, you're going to start to see their O2 sats start to drop. Maybe because of some clotting and some PEs that are going on in the lungs, right? So you're going to start to see maybe their oxygen levels go down. You're going to start to see some cyanosis and some, blueness going on in some of the parts of the body. It's also not uncommon to see now, because of this lack of perfusion to the tissues, whatever part of the body we're talking about, it's also not uncommon to start to see metabolic acidosis. Why? Why would you see metabolic acidosis in a person who's got some pretty profound clot formations going on? Why? What do you think? Put the pieces together. Say it again. Keep going, yes. Okay, good. So you're not getting enough oxygen to the organs, right? You're not getting enough oxygen to the organs because of the clotting, that's basically causing a log jam, so to speak, in the blood getting to the tissues, right? When tissues don't get enough oxygen, the clots are basically blocking adequate oxygen perfusion to the tissue. What happens? Lactic acid buildup, right? Because you don't have proper aerobic cellular respiration going on. You can't meet that ATP production quota, right? And so instead of getting oxygen to the tissues and oxygenating that tissue properly, you now switch into sort of anaerobic cellular metabolism instead of aerobic. And what is produced by anaerobic cellular metabolism? Lactic acid. Lactic acid is an acid, and it's going to start to build up in the body and cause metabolic acidosis. Their pH is going to be super low, right? These are sick, sick, sick patients. They're metabolically acidotic on top of whatever trauma they came into the ER for, right? And now, after those platelets and all those clotting factors have been used up over an extended period of time, now it's not going to be abnormal at all to start to see them start to bleed from everywhere, right? I've seen patients bleed, start to ooze, literally ooze, from every single place on their body that they've been stuck for a venipuncture, that maybe they start to ooze around the site of their central line. Maybe they start to ooze from where I just tried to get an ABG, right, to the little, the little pricks in their skin from an ABG. This is where you start to see profound purpura. So they just have these big collections of blood under their skin everywhere. Petechiae, hematomas, right? This is the clinical sort of play out of what DIC looks like, right? Some sort of initiator, trauma in this case, profound clotting, maybe some metabolic acidosis sprinkled on top, right, because of the clotting and the lack of oxygen to the tissues. Then you're bleeding. and the bleeding that you cannot get to stop. I mean, I've literally seen patients bleed from, literally every orifice, every venipuncture site, from their Foley, from their IV site, everywhere. Now, I wrote here simply on the screen, treatment is to remove the stimulus. How do you easily remove a stimulus of a patient like this, right? That's why mortality rate is so high in these types of patients, because they're so complicated. From start to finish, these patients are so complicated. And that's DIC. Major critical care diagnosis. That if you spend any time in the critical care arena at any point in your career or in your education, you'll see it. Or some form of it. Maybe right before, maybe right after sort of situation, but you will see DIC. All right. Any questions about that? Yeah. Yeah. So that's what I mean. Like it's easy to say, right? If it's a trauma patient and they've got some profound endothelial damage, fix the endothelial damage. Yeah, right. It's a process of them healing and getting better and whatever trauma was there. It's a process of that healing. Now, that's a lot easier said than done, right? When it's a profound crush injury or whatever it may be. So what I mean by that is, in the ideal, if everything happened in a vacuum, you would just fix that problem and then DIC would go away. But it's really hard to fix this problem, and therefore DIC doesn't go away, and mortality rates are really high. Yeah. Well, you're bleeding out. See you later, bud. It's going to be an issue of trying to fix whatever the problem is. So if they're bleeding, then you're going to try to be fixing that. So is it a matter of vitamin K? Is it what can we give IV? It's basically just whatever the issue, palliative, whatever the issue is. Yeah. There can be, right, so just like how you would treat like a hemophilia, there are like supplemental clotting factors. So that could be something that may be used. Depending on the situation, it may or may not be that helpful. Yeah. But yes, there are. Yeah.
How fast are you going to see this progress?
It depends on how profound the injury was or how profound that initial trigger was. It could happen within, the whole process can start within a few days. If the patient's, sometimes because it's an ICU, it's the kind of thing you see in very complicated ICU patients. It may not be initially from the trauma, right? Maybe they're doing pretty okay in terms of the trauma, but now maybe they start to get septic, and maybe it's the sepsis that actually causes the problem. So it's kind of hard to say, oh, you're a trauma patient, let's look out for DIC within 48 hours. It's kind of hard to put a number on it. But very complicated. All right, good questions. Where did my mouse go? There we go. All right, so we're going to end there and go to the kids. And a lot of the kids' stuff, especially toward the end of this kids' lecture, is sort of repeat from things we've already talked about in terms of alterations. So some of it's going to be just kind of supplemental, a little bit more information for you, maybe through the lens of the pediatric population, et cetera. But a lot of it's going to be kind of familiar to you. Okay, so chapter 21, alteration of function in the children. Here's some objectives. Yeah? Yes. That's DIC. Thromboembolic disorders, yes. 12 is DIC. She was asking you about the last objective on chapter 20. It says characterize thromboembolic disorders. That's DIC. Yeah. And again, I just sort of said that that's sort of the classic clinical example of a thromboembolic disorder. Yep. All right. Objectives for chapter 21. Okay, so acquired disorders of the erythrocytes. We're going to talk about acquired disorders, and we're going to talk about inherited disorders of the red blood cells to start off with. So the first acquired, and by acquired, right, I mean it just kind of happens. You acquire it. It's not like it's a congenital problem that you're born with. The first one we're going to talk about is iron deficiency anemia. Now, we talked about this already. We talked about the adult population. Remember I said some of this is going to be kind of familiar sounding. But I want to show it to you through the lens of pediatrics. So iron deficiency anemia is the most common blood disorder of infancy and childhood. And we've already talked about how iron deficiency anemia truly is just basically caused by lack of iron intake or blood loss. Now, it's probably not going to be so much the blood loss in the pediatric population. It's more going to be these issues of proper iron supplementation or intake. Why might this be so common in children? What does the pediatric population, what is their sort of unique situation and that they are at such high risk of iron deficiency anemia? What do you think? It's not that they're bleeding. It's not that they have got some sort of occult bleeding in their colon, right? Yeah.
Is it like their diet and their growth being imbalanced?
Perfect. Couldn't have said it better myself. One, they're picky eaters, right? They may not be getting in the proper amounts of iron through their diet. And two, their need for iron is extremely high because of for normal growth to occur, right? Their growth curve is so much sharper, so much steeper than ours as an adult, right? So they already need more iron than we do, and then they're probably not eating as much iron as we do, right? So it's this double whammy. It's this double-edged sword of lack of iron for them. Now, the signs of anemia are the same in children as they are for adults, right? The problem is what, though? So we said, right, that the signs of anemia is listlessness, fatigue, malaise, feeling kind of winded and short of breath, just kind of feeling tired. Why is that a problem in the pediatric population? Or maybe not even pediatric, but infant population. Why would that be a problem with a 7-month-old? How are they going to tell you that? Yeah, right. How's my 9-month-old daughter going to say, well, I'm just feeling really listless and malaise, Mom. I'm feeling very malaise as I lay here in my crib. So that's the issue, right? Is they can't communicate that to us the same way that, a 65-year-old man's going to, right? And so they're unable to describe these symptoms, and therefore parents don't know it, right? They don't note any of these changes until we've got some moderate to severe anemia going on, right? Because it's gone on for so long because the child, the baby, the whoever, hasn't been able to sort of relay that information. So oftentimes when you see iron deficiency anemia in a child, it's pretty severe because of that reason. So manifestations in a kid or a baby or, a child may look like irritability. They're just crabby all the time because they're tired all the time, right? Decreased activity intolerance. This is, a 3-year-old little boy who's constantly wanting to go to the park, constantly wanting to run around, constantly, Mommy, play with me, Mommy, play with me, Mommy, play with me, Mommy, play with this. I'm sorry. It's my personal life coming into my lecture. No, I'm kidding. Mom, play with me. Please go to the park. Never wanting to go, right? Laying on the couch. Okay, that's not normal, right? Weakness, just all those types of things. So it's not going to be the same types of symptoms that you see from an adult. It's going to be these kinds of things. Now, so if that's the case, and it can get pretty profound, what do they do? How do they sort of look for this or screen for this? Well, it's a pretty routine check. It's a pretty routine blood test at their 12-month well visit when they go to see the pediatrician to check for iron. Because again, it's not good enough to wait until symptoms because by that time in a child it's pretty profound. So it's pretty common to check for iron at the 12-month well visit.
Is that a blood test?
It's a blood test. Yeah, it's a blood test. Yep. Yep. And again, it's not a difficult fix. I mean, it's just literally like an iron supplementation if it's low. All right. The other type of acquired disorder of red blood cells is the hemolytic disease of the newborn. Now, we talked about this when we talked about alloimmune reactions last semester, right? So do you guys remember this? Do you want me to kind of briefly kind of review this with you, or you want to do that? Okay. So this is an autoimmune disease. We talked about this last semester when we talked about the immune reactions. Now, this is the type of reaction that only occurs if the antigens on the fetal red blood cells differ from the antigens on the mom's red blood cells. So it's an Rh incompatibility. Now, we'll go to the next slide. And so this is a good illustration, but I'm going to be saying a lot more than what's actually on this slide. So if you want to kind of jot down notes, I'll try to talk slow so we kind of stay together. Okay, so what happens in the hemolytic disease of the newborn is that first you have an Rh incompatible pregnancy that generally presents with no difficulties, right? But this happens with an Rh negative mom. These hemolytic diseases of the newborn are always going to occur with an Rh negative mom and an Rh positive fetus. Okay, I'll say that again. It's an incompatibility that where you have the mom who is Rh negative and the fetus who is Rh positive. Now, if this occurs, there really is no complications to the pregnancy at all. Mom does fine, baby does fine. The reason for that is that there are very few fetal red blood cells that actually cross the placental barrier during pregnancy. So there really is not a lot of true mixing of the blood between mom and baby during pregnancy. It's during birth, when the placenta detaches, that a large number of fetal red blood cells then gets into the maternal circulation. Okay, so again, it's during birth when the placenta starts to pull away, that's when a large number of baby red blood cells gets into the maternal circulation. What do you think happens when the Rh positive red blood cells of a baby now gets into the Rh negative red blood cell circulation of the mom? What happens? The mom creates antibodies, right? The mom creates antibodies to those positive red blood cells. Does anything happen to the mom or to the baby? No, they do fine. What's the issue? The next time she gets pregnant, she has those antibodies in her blood, right? So now if she has another Rh positive fetus, her body will attack that fetus. Her body will hemolyze. That's why it's called hemolytic. It will hemolyze. It will destroy those Rh positive red blood cells of that fetus. Very good. All right.
But we're going to talk about that. There's a med.
Yep.
page.
Rogam.
Gotcha.
You're one step ahead of me, girl.
Sorry.
Okay. So, but first, before we talk about the treatment of it, let's talk about if you don't treat it, what would happen? So under natural progression of this disease, what happens? Okay, so obviously you're going to see anemia of the fetus. And I don't just mean of the baby when it's born. I mean in utero, the fetus will be anemic, right? Because their red blood cells are actively being destroyed. So if you're going to see anemia, so you're going to see a low number of red blood cells, you're going to see hyperbilirubinemia, because remember, bilirubin is sort of the byproduct or of the breakdown of red blood cells. So you'll see a lot of increased bilirubin with a lot of breaking down of those red blood cells. Yeah. Yes, this would now be the second child. Right, sorry. Yes, this would now be the second child, like I said, if you don't treat it. Right. Okay, so now this is the second child. So anemia, hyperbilirubinemia. You're going to see jaundice, obviously, of the newborn when they're born because of the hyperbilirubinemia. And if it's so bad, if you've got such high bilirubin levels, you can actually see bilirubin that deposits in the brain. That's called kernicterus. So really high bilirubin levels can actually cause neurologic damage. It can actually cause brain damage in the next baby, right? And again, some of this will occur in utero. So this is not like, oh, okay, once the baby's born, we can kind of fix this. This is happening before the baby is even born, okay? So because of that, this fetus may not survive because of this profound anemia and these other profound complications. And you'll see a lot of these babies that have not, where the mom has not been properly treated, be stillborn or even, miscarried because of these profound blood issues in utero. All right. Now, it doesn't have to happen, right? It's a very simple fix for how we can fix this hemolytic disease of the newborn. So, back it up. Go back to that first birth, right? If that was properly treated with a preparation called Rogam, it's an Rh immune globulin, right? It's an IM injection that you give to that mother that prevents her body from making those antibodies to those Rh positive red blood cells. It's a one-time deal. It's a one-time injection. And you would give it to a mother who is Rh negative anytime she has basically removal of the placenta. So that means after a live birth, normal term birth. It also means if she has a miscarriage, she would get RhoGAM after a miscarriage. That's when I have actually given RhoGAM, is in the ER when a woman's coming in, sort of during a miscarriage. We would do a type and screen, find out that she's Rh negative. We'd give her RhoGAM. We don't even know what the Rh, is of the fetus. We just cover her with the RhoGAM, no matter what, right? Because we know she's Rh negative. There's no reason to risk it. Just give her the RhoGAM. So anytime there's loss of a placenta, you're going to give RhoGAM, be it a live birth or be it a miscarriage. And that will prevent this hemolytic disease of the newborn occurring with her next pregnancy. Yeah? It can be after. In fact, it just needs to be within like 72 hours after, loss of placenta, loss of pregnancy, end of pregnancy, whatever. Yeah.
So that's just like routine in the hospital? You don't
Yes.
test the baby just after every birth?
It's just routine. So it's very routine to check the blood type of the mother. In fact, that's one of the tests you would do, like, the OBGYN would do that in sort of the early sort of pregnancy labs that you would do. And if the mom's Rh negative, you always give it, no matter what the blood type is of the baby. Because oftentimes we don't know the blood type of the baby, and especially if the mother's currently pregnant, there's no way to sort of test the fetus blood, So we always give RhoGAM anytime the woman is Rh negative. Now, what happens if we don't, and the baby is born, and they do go into sort of hemolytic disease of the newborn sort of after birth? These are going to be pretty sick babies. I'm not going to say that it's not just a really simple sort of fix, but one of the things they will do are do exchange transfusions of new Rh positive blood to that newborn, and basically just kind of clear out all that old blood that has those antibodies from the mom in it, and just give them new, fresh Rh positive blood. And usually that can fix the situation. Yeah?
Is there anything to be done for the mom? Like if they miss that RhoGAM shot, she knows the antibodies over and done with?
Like if she would have the baby and not get RhoGAM within 72 hours and then end up getting pregnant again? No. Yeah. It has to really be in that short window of like 72-ish hours. That's why, again, it's really important, especially if the woman knows that she's Rh negative and she is miscarrying, that she seeks medical treatment, that she doesn't just, try to miscarry at home and not seek medical treatment, because she needs RhoGAM. Yeah. In a timely fashion. Yeah. Every time. Then again, let's say she's got a third pregnancy and has the baby. You would give RhoGAM after that delivery as well. Yeah, every single time she's no longer pregnant anymore. Yes. And that will protect any future babies. Yeah.
So why doesn't, like, if the mom's Rh positive and the baby's Rh negative, like, why I don't know, why isn't that?
Because it has to do with, it's the same kind of thing as like your blood type, right? It's only the Rh negative blood that's going to create an antibody to the positive. Positives are not going to create antibodies to negatives. Yeah, same thing as like your blood type, like your ABO incompatibility. It's the same kind of reason. Only negative is going to have those antigens on it to create the antibodies against. Yeah, good question. Good question. Nothing. There'd be no problem. There'd be no problem. Right. It has to do with the antigens that she has on her red blood cells. Yeah. One more question, guys, then we're going to move forward.
Do you know why we biologically developed like this? Like what's the
Why we have those antigens?
or why is it
That's a good question. Why would our body do such a thing? I don't know. There's an evolutionary reason for it. I can sort of look into it for you and maybe try to get back to you on it. I don't know that I really have a good scientific reason for why we have those antibodies and antigens in our blood. Good question, though. I like how you're thinking. All right. Any more questions about hemolytic disease of the newborn? Okay. The next disorder of erythrocytes that I want to talk about is sickle cell disease. So sickle cell disease is a disorder that's characterized by the presence of an abnormal hemoglobin on that red blood cell. So again, just to get technical for you, the reason that it happens is that what happens in sickle cell is that one of the amino acids is sort of a genetic mutation. One of the amino acids, valine, replaces another one, glutamic acid. And because of that, it changes and makes that hemoglobin on that red blood cell abnormal. So then what happens because of that is under certain conditions, specifically deoxygenation and dehydration, the red blood cells of the people that have these abnormal hemoglobin on those red blood cells solidify and stretch into these really sort of elongated sort of sickle shape to them. So instead of that normal sort of biconcave donut shape, their red blood cells under deoxygenation and dehydration are sort of shaped like this, right? Instead of those nice little donuts. My pen is running out here, but you know what I mean. You know what I mean. Okay, so, and again, it's a genetic issue. It's an autosomal recessive disorder that causes this. So that being said, what kind of triggers do you think would trigger these blood cells to change shape? Now, I will tell you, it's only during these states that these red blood cells change shapes. They can go back to being that biconcave donut shape. But it's under these states that these cells take on this shape. What would be some states that would cause deoxygenation or dehydration? Altitude's a great one. Yep. Exercise is a good one. Or especially exercising in like a hot climate. Yep. Or exercising in a high altitude climate.
Isn't it like for females when they're on their period?
I don't know. I mean, maybe if they're like dehydrated on top of it,
I feel like
sort
a
of
lot
thing.
The ones that we get over at Tony University.
Yeah.
Hemos,
Yeah.
like, a lot of the times they have a crisis
When they're interesting. Okay, I would have to look into that a little bit closer. She said, you know, when a female is menstruating, perhaps. Maybe it has to do with their lack of volume. You know, like maybe they get a little hypovolemic.
Yeah, there was the one that we talked about where it's not that they have a lack of or increased red blood cells, but it's they're dehydrated.
Yeah, it could be. Yeah, I would sort of put that in that category. Another one that I would sort of include in that is being sick. You know, being ill. You can certainly be you're more at risk for being dehydrated when you're sick or you have a fever or something like that. So it's not abnormal to see patients like in the ER come in with a sickle cell crisis because of one of these conditions that we've just talked about. And again, you see it a lot more in the summer because of dehydration and things like that than you do in winter months. So it's an autosomal recessive disorder. It also tends to occur in persons with hereditary sort of genetic origins in equatorial climates like Central Africa, South and Central America. Anyone know why that is evolutionarily? Yeah, Dylan? Right. It was a protective mechanism, evolutionarily speaking, to malaria. So they needed it in those climates to sort of prevent malaria from occurring. Unfortunately, it doesn't do our patients here in Kansas City a lot of good. And so that's the issue. Now, the problem is that you can either have sickle cell trait, which meaning you just inherited one of those abnormal autosomal recessive genes, or you have the full disease, which obviously means you have two abnormal genes because it's autosomal recessive. So you need two to actually have the trait itself. So you need two of the abnormal genes of the abnormal hemoglobin. Okay. So what does this mean? What does this look like for our patients? What's one of the main sort of signs and symptoms that your patients in your hemonc unit complain of with sickle cell crisis? Pain. Exactly. Pain is the big one. And the reason for that is this very first thing here up on the screen. It's because of vaso-occlusive crises. When you've got some sort of deoxygenated or some sort of dehydrated condition or status, it changes the normal shape of the red blood cells more into these sickle-shaped cells. That means that they lump together easier, they get caught on each other, and two, they can't squeeze through that little microcirculation as well and as adequately as normally shaped red blood cells do. So what happens? They get clogged up. They literally form like a logjam effect. And you get, so when you get sickling in the microcirculation, blood flow gets obstructed because of this logjam, essentially, of these abnormally shaped red blood cells. And unless you reverse that, you get thrombosis, you get clotting in that area, and you get infarction. You get lack of blood flow, lack of oxygen to those tissues, and it causes severe pain. Some of the places that you'll hear it, patients complain of it the most are like in the chest, in the back, in the limbs. You'll hear of those three as sort of the highest places. You'll also see patients with sickle cell be in aplastic crisis, as you see here second on the screen. They're also at really big risk for aplastic crisis, which is basically like a profound anemia. And again, profound anemia caused by, why do you think? If you've got these weird shaped red blood cells, what do you think happens to those weird shaped red blood cells? They get destroyed, right? And so your body destroys all these abnormal red blood cells, and your body can't keep up fast enough with making new good red blood cells, and they become profoundly anemic. I can't tell you how many sickle cell patients I've taken care of in the ER who I've given like emergent red blood cell, transfusions to, blood transfusions, because their, hemoglobin is, 6. You'll also get sequestration, again, because you have all these broken down red blood cells. They'll all get sequestered in the spleen. And so then you've got, like splenomegaly and those types of problems going on. And then, again, I sort of said already, but they're hyperhemolytic. So they're increased tendency for their red blood cells to get hemolyzed, for their red cells to break down. So given what I just said, that dehydration and deoxygenation are the problems that cause these red blood cells to sickle and change shape, that causes the logjam in the circulation, that causes the pain, what do you think you do? What's treatment? If someone's coming into the ER in a sickle cell crisis, what am I going to be expecting? I mean, what's kind of automatic in terms of treatment for these patients? Say that again? Pain meds, oxygen, and IV fluids. Boom. Those are the three right there. IV fluid administration, lots of pain medication, and lots of oxygen, right? And with specifically the IV hydration and the oxygen, you can actually change the shape of those red blood cells again. What happens, here's a good picture, just so you see it real here. Here's a good picture of this abnormal sickled red blood cell. Reversal of hypoxemia, by reoxygenating them and rehydrating them, the sickled erythrocytes actually regain normal shape and they resume normal function, and that crisis goes away. What happens if you don't reoxygenate and rehydrate? They get super sick. I mean, you're talking about lack of oxygen to the tissues, lactic acid building up, metabolic acidosis, etc. People can actually die of sickle cell crises, of those vaso-occlusive crises that don't get treated. Yeah, like. Yes, they can actually go back to the normal bioconcave shape. Yeah, yep, yes.
Do they always have to come into the hospital, or is there any?
If they know that they can sort of rehydrate themselves, sometimes I'll have patients say that, like, I'm just coming in because I have tried over the last day to drink a ton of fluid and stay hydrated, and it's not working. I'm still in a lot of pain, but you can't really oxygenate at home. So oftentimes they'll come in for oxygen. Yeah. Okay, guys. The last part of the lecture, let me just kind of quickly talk to you about. So the thalassemias, this one, inherited disorders of erythrocytes, thalassemias, those are just going to be kind of your FYI. Oftentimes I do not cover that in class. I just put it here for kind of your FYI. So you can cross that objective off your list. You will not be tested on it. So thalassemias, as you flip through all of those slides, you will not be responsible for. Hemophilia, I want you to just kind of look over. There may be one question on the test about that, and I will tell you it's going to be a really straightforward question. Like, if you are short factor 8 in hemophilia A, how do you think you would treat it? Give you factor 8, right? So that's just kind of what I want you to know about hemophilias. And then if you look at the rest of the lecture, it's stuff we've talked about already. So it's ITP, it's leukemia, and it's lymphomas. And like I said, the pathophysiology is the same. I just wanted to kind of include it for you for your FYI within the pediatric population. Okay? So yeah, I mean, you'll still be responsible for it, but you're going to be responsible for it anyway. It's the same pathophysiology. Okay? Thanks, guys. I'll see you Thursday.